Hey, thanks for having me. I'm Alex. I'm one of the interventional radiology fellows at Rush in Chicago. My attending and I had a bet that there would be enough millennials in this room to at least appreciate the Sum 41 reference in the title, so I need a couple people to chuckle at least. All right, so no disclosures. So patient history, we have a 75-year-old male with past medical history that's pretty standard for a lot of our PAD patients with this disease cocktail. He was admitted with purulent drainage from his toe amputations, and subsequently they performed a TMA. So he presented to our clinic with non-healing right TMA stump with this large eschar on top of it. He had ABIs, but they were non-reliable. We looked back at his ABIs from before he had the TMA, and he had a TBI of 0.41 on that side, and then subsequently, right before the TMA, it was a 0.25, and his toe pressure was 80. So at this point, we decided to go ahead with the angiogram. So we did a right lower extremity angiogram. It shows that he has flow in his PT all the way down to his plantar artery and in his perineal, but his anterior tibial artery stops at the level of the ankle with no flow into his dorsalis pedis. So we decided to further catheterize the anterior tibial artery in order to identify any hypernating vessel. This further angiogram shows that he has a pattern of small artery disease without an anastomotic target for bypass. So at this point, we have to consider what our options are. We can do a BKA on him, but BKAs have relatively high mortality rate at 30 days, which progressively worsens over time. On top of that, the patient was uninterested in having a BKA. So in no option patients, the only option is a DVA that we could offer. Most commonly, the DVA is created using a PT artery when you have a desert foot and you have the option of whether you want to use the PT or the AT. Our patient's PT artery was intact, so the only option here was the DP or the perineal. The reason that we generally choose the posterior tibial artery instead is because of the better angulation if you're doing a proximal one, and distally, the crossing from the artery to the vein allows for a better plane so that you can do that. So how we prep our patients for a DVA is we prep the entire leg with the entire leg out. We prep both the back and the front, obviously. Here we have our access when we're accessing the anterior tibial artery just above the level of the ankle. The vein. Ideally, we would access the vein in the foot, but because of the large eschar there, we were unable to. And then this other image shows our anterior tibial vein higher up. So to cross, we used a 6 French 80 centimeter outback, and we punctured into the vein where the 5 centimeter balloon was. Some people will use the Pioneer catheter for this. Some people use a double gun sight. At this point, when we did this procedure, we were still using the outback just because of our comfort level with that. We've now gone to actually using the lymph flow system. So this shows our wire looped in the terminal segment of the or the lower half of the anterior tibial vein, and then this shows our wire and catheter on the other image in the pedal venous loop. Before we did this ballooning to break the rest of the valves, we ended up getting flossing access by pulling out our balloon, taking our hydrophilic wire and then placing a crossing catheter over that, and then using a valvulotome also. This just shows us breaking the remainder of the valves. Like the posterior tibial vein, there's a valve right at the level of the mid-ankle in the anterior tibial vein, so this is us breaking that vein, or that valve. So after this, we did a DSA, and it shows that there's sluggish flow in this newly created or newly arterialized vein. And we didn't know if that was because there was a clot in it, or if there was just a valve in it, as there sometimes is, or if there's some stenosis there. But this last one shows that there's still sluggish flow after a repeat injection. So we did another injection with imaging a little bit lower down. Let me just skip forward a little bit here. And this shows what was the cause of it. We had extravasation from the distal aspect of our arterialization here, with contrast going into the soft tissues. So at this point, we decided to throw up a balloon to try to tamponade this, But after balloon tamponade, there was still some extravasation. So we placed another covered stent further distally in the anterior tibial vein here. Just another view of it. And then we did another DSA, which shows that there's still some extravasation at this point. So unfortunately for us and unfortunately for the patient, our only option at this point is to try to occlude it. Going back to these slides, it shows that what we thought was likely a loop from the valve in the distal portion of the vein here, or the proximal portion of the vein, I guess, was likely that we were subintimal and perforated at this location. And what we thought was in the pedal venous loop was actually in the soft tissues. So this is our amplatzer plug that we placed in the proximal arterialized vein, and then did a final angiogram showing that we have no more extravasation, but unfortunately also no more DVA. So an update on the patient following this, he ended up undergoing a BKA anyways and still had continued purulence from the stump, and then unfortunately passed away from multiple other comorbidities in July of this year. So just a couple points to remember on this. Always got to have caution whenever you're crossing veins and valves are retrograde, even if you use a valvulotome to try to break the veins in a balloon. You should always check for blood flow prior to actually stenting, which we did not do before this, and then get pedal access if at all possible to avoid that situation. But despite all that, I think anterior tibial vein DVAs are definitely a viable options for patients that have no other options. Thanks.